Hello, thank you everybody for joining in. I would like to first start by introducing our panelists. Dr. Darren Summers is an internal medicine physician who never really planned to work in telemedicine, but after a brief residency at Fort Bragg, he found himself in Afghanistan taking care of pretty sick people in some pretty austere environments. After returning home, he took a job in rural communities of North Carolina where he found himself taking care of people in similar health situations without the support of the telemedicine infrastructure of the military. He says that he figured if we could do it in Afghanistan, we can do it here. And so 5 years ago, he founded a technology company, Innovator Health, to bring a personal interaction with remote physicians to patients who might not otherwise have access to their expertise. Thank you, Dr. Summers, for being here with us today.
Thank you.
And our next panelist is Dr. Julie Gentili, a psychiatrist at Wright State University who has been using telemedicine since 2010. She works with a specialized patient population with psychiatric conditions with co-occurring intellectual and developmental disabilities and patients with traumatic brain injuries. Starting in 2003, traveling the state for a state-funded research project, she found that in rural and outlying areas, mental health was being addressed by primary care physicians, where there was a desperate shortage of psychiatric care. This was a catalyst for a statewide project that today treats 1,600 patients with co-occurring diagnosis in utilizing telemedicine in cooperation with local health professionals with amazing results. Julie, thank you for being here with us today.
Thank you for having me. It's my pleasure.
So let's go ahead and get started. I'd like to start with the question, tell us about an instance where you personally witnessed the power of telemedicine to address a health issue or health issues that might have been handled differently had telemedicine not been an available option.
You want to go first, Julie?
Sure, absolutely. Right. So since I've been doing telemedicine for about 10 years now, we've had lots of instances. A couple examples, we've had patients who are suicidal, for example, and instead of having to be transported to emergency services, we can see them using telehealth immediately. It's a regular appointment, you're assessing the patient, you can patch them in with local resources, utilizing collateral data sources and caregivers. And so we can actually facilitate involuntary hospitalizations long distance. It's not ideal, of course, but that's one of the things that we learned early on. You have to communicate clearly what you can and cannot do when you're providing long distance care. For example, I can facilitate a hospitalization long distance by providing historical information and communicating effectively with emergency medicine personnel, for example. Another thing that I've really appreciated about telehealth is that I can see into someone's own space. So I can see into someone's home, for example. I can pick up on details of their lives that I would never realize in my office setting. So I might notice that a child exposed to secondary smoke. I might look at family dynamics. I might get to meet siblings or pets or other parts of individuals' lives that I wouldn't be exposed to. I can also assess for lithium toxicity, for example. I can do everything via telehealth that I'm doing in the office setting, and I can patch people into local services quickly as needed. And I also, I think when I traveled the state, one of the things that was really striking to me was that there aren't local services for some individuals. People are desperate for specialty services, including psychiatry. And so to be able to enter using technology into their own homes, schools, or programs really facilitates care and well-being.
Ready? All right. So I've been practicing as a hospitalist for about 15 years and converted into a completely telehealth practice about 5 years ago. So I see between 3,000 and 5,000 telemedicine visits a year. And in my practice, I'm very clinically oriented in the sense of having to use medical devices. So digital stethoscopes, digital cameras, nurses at the bedside, and so very sophisticated use of the equipment. But similar to Julie, I can do about 90% of my normal internal medicine practice as a hospitalist, so a physician taking care of patients just admitted to the hospital, with the use of the telemedicine equipment. And so what's interesting is the family dynamics that are involved in the use of the care. Patients that are sick, appreciate the fact that you can sit and talk with them. It doesn't much matter if I walk into a room physically, turn my back to a patient, and am distracted by my phone or computer, versus being on a screen and looking at them. The interaction is what's most important with the patient and with the family. And so those dynamics are really important to preserve and to maintain. And so to answer your question, Bridget, when I'm also an Army reservist, and earlier this year I was activated and mobilized to New York City for the COVID response, and we're able to pilot some of the telemedicine equipment there and expose ourselves to the workflow. When you're setting up a telemedicine program, you have the ability to train everybody and work with everybody, and people are familiar with it in advance. It's a lot easier than trying to do that on the fly. So how do you get a group of people to use it that have never used it before? And what was really interesting about that experience was the first time the cart rolled into the room and we saw our first patient, the patient got a huge smile on their face. And I said, do you like telemedicine? He goes, I've never done it before, but you're the first face I've seen without a mask on in like 6 weeks. And I'm like, well, sorry about that, but thank you for the compliment. So it was kind of funny because you really you lose sight of what people are thinking and how they're interacting. So to actually see a smile on somebody after 6 weeks of seeing masks and gowns and everything is really profound. So the value of telemedicine is really in how we set it up and use it, right? How engaging is it? Who's the physician on the screen or the other healthcare professional on the screen? How is the dynamic interacting with the patient and the family? And so there's so many opportunities to really get a great experience if we do things correctly. And I find it's just as rewarding for me, even though I've been doing it for more than a decade now, as it is for my patient population.
Building on that, Julie, you mentioned earlier about how not only when seeing into their space gives you a window, but that you have found that patients feel more comfortable sharing things when they're in the privacy of their home. Can you elaborate on that a little bit, building on what Darren was talking about?
I sure will. And just hearing Darren talk reminds me of several other instances where it's just been this incredible opportunity. I think that during the pandemic in particular, we're able to help connect people who haven't seen each other. So our software allows us, we have a virtual waiting room, so I can look in the waiting room, I can pull my patient in, I can go back out and I can pull in a mom or a dad or a guardian who's in another location, because our patients have intellectual and developmental disabilities. They may be living in supported residential settings. They may be in intermediate care facilities, nursing facilities. So I can patch people in who don't have the ability to see each other in person. And so when you see a daughter reunited with a dad, for example, on the screen for the first time, because they don't have the capability of the software to do that on their own between appointments, it's incredibly special. I also have patients who are who I switched from an office setting to telehealth. And so I was able to see that transition, which was really powerful. So I had patients in my office who I had known for a few weeks or a few months, for example, and then switching to telehealth, they were revealing more about their personal stories. They were more conversational. They felt safer, you could tell. We have an exemption from the Centers of Medicare and Medicaid, and so that our patients, because of their functional limitations and multiple disabilities, they're able to choose a location of their preference. And this was even before the exemption was lifted. So we've been able to do this for about 10 years. So seeing someone from their own school, or of course a private area that's HIPAA compliant, but from their own office, et cetera, they talk more. Their guard is down. They feel safer. There's something about the security of the software, and they're able to share things that I didn't know about them. And so it helps me do my job and make better clinical decisions, honestly. We also have patients that are it's not safe for them to travel. patients with severe and profound intellectual disability with these limitations that being in enclosed spaces or traveling for 2 or 3 or 4 hours, it's just not an option. And I also think it allows us there's this pyramid effect where I've worked with internal medicine doctors who are medical directors of nursing facilities, for example. And so they can join the appointment. It's sort of a buffet menu. It can be doctor-patient or it can be doctor-doctor. So you can have a team in a room and you can talk to them about obsessive compulsive disorder and serotonin reuptake inhibitors and prescribing. And so he had touched base with me after the fact and said, I prescribed those medications for that patient, but it was also helpful to me to treat other individuals with other anxiety disorders within our facility. So there's this pyramid effect where there's some isolation in rural and underserved areas.
Jumping back, Darren, you mentioned when you were explaining some of the things about telemedicine equipment, digital sensors. Before we move on to the next planned question, can you talk a little bit more about what that means? What is telemedicine equipment?
Sure. So I think when we say the term telemedicine, it means something different to everybody. And I think it's like saying an X-ray, right? Is an X-ray a plain film? Is it an MRI? Is it a CAT scan? And so I think we have to be specific about what we're talking about. We talk about telemedicine. So are we talking about something simple like what we're doing now, a conversation between us and the audience? Or are we talking about something more sophisticated like electronic ICU? And so there's a spectrum of services, right? So think of it like a bell-shaped curve, if you will, of items and devices that exist to allow a more comprehensive exam. And so I teach a telemedicine training program. So we created the first telemedicine curriculum for U.S. medical school at the NYT College of Osteopathic Medicine in Jonesboro, Arkansas. And so when I train the students, I talk about the typical exam and I shape it in the form of a SOAP note. So when you think about a SOAP note, that's the subjective, objective, assessment, and plan. The subjective portion, the assessment, and the plan are really all conversational. Patient telling me what's going on with their illness, what I think is going on, and how we're going to manage it. The objective portion is the hands-on. And typically that includes the vital signs, which are most likely, even in a modern medical practice in person, is done by the nurse on site. And then we have the visualization of what I'm looking at, the auscultation of what I'm listening to, and the palpation of what I'm feeling. With a digital stethoscope and a digital exam camera, in some ways, I can get a better sound and a better view of what's going on with a patient. So palpation really is the only main difference between what I do in person and what I do by video. And so when we have well-trained nurses at the bedside that can push on a belly and I see a patient guard, I know, okay, they've got tenderness. Now I might have to ask the nurse, is the belly soft? Do you feel any masses and things like that? And so with time and experience, they learn that very quickly. And so the equipment is what the practitioner needs in order to deliver the exam of their choice. And that ranges anything from like what Julie does with just 2 PCs to maybe an ear, nose, and throat doctor that uses a scope to look in the back of the throat, or an internist like myself that uses a stethoscope and digital cameras to examine the patient, or an EICU that has sophisticated patient monitoring that can tell what the heart rate is and EKG tracings and vital signs.
Okay, thank you. That actually leads well to our next question, which is, what are some of the biggest obstacles in telemedicine today? And are there commercially available technologies that you think your industry could adapt and make telemedicine more effective?
So I think the biggest obstacle for telemedicine today is really not a technology issue. I think it's a billing and coding issue, because telemedicine is this big kind of vast nebulous industry right now. I think Medicare, as an example, doesn't really know how to bill and collect for those services or to set up a standard. And my hope is that at some point they look at telemedicine and say, look, if you're meeting the standard of care through technology in the same way that you would in person, then we're going to just reimburse you the same. And I think what's really affected the growth of telemedicine is the fact that when the COVID response hit, they opened up the billing and reimbursement so that it was wide open. Now, what we're doing is we're allowing reimbursement for services that are not as sophisticated as the in-person exam. So I think they're going to contract some of that back. But I think that's really one of the big obstacles. The other one is the bandwidth access. So in an urban community where most of us are in today, bandwidth's not a huge issue, but in a lot of rural communities, bandwidth is an issue. So we either have to figure out ways of improving bandwidth to local communities, which they're trying to do through grants, or trying to figure out how we develop more sophisticated technologies utilizing less bandwidth. And there's a number of different ways that that can be done. But I think having increased access to the broadband capability and improving access to billing and coding reimbursement services so that we can get equivalent funding for programs that don't rely on grants, that these can be self-sustaining, I think are the two biggest things that can really grow this industry. And I think we've seen some of that in the last 6 months.
Julie, would you like to build on that?
Thank you. Yeah, I agree with everything that Darren said. And we also have the same billing and coding issues. Another issue that we have in addition is that we work in public psychiatry. And so we are serving a patient population with very little resources, personal resources. So we have a lot of patients in these outlying communities who don't have computers and don't have connectivity. And so that's an issue for us. And in particular, as Darren was saying, Southeast Ohio seems to be a really difficult area for individuals to have access the high-speed broadband internet that they need. But what we've done is the partnership and the collaboration with local county boards of developmental disabilities has been incredibly helpful for us. And so we have tasked each local board of DD to make available a computer system and a webcam for the family or the individual on the day of the appointment. And so that could mean they have this private office set up in the county board of DD and the patient travels in and uses that office and their equipment. Or it can mean that the services and supports administrator or the case manager drives to the family's home on the day of the appointment, sets the computer up in their home, and then navigates the appointment until we're off and running. So that's how we've tried to fill in those gaps. But the other thing that I've noticed is that clinicians who trained more more remotely in the remote past are less accepting or receptive to the use of technology versus our resident physicians, for example, and our more newly trained faculty. And that's actually shown in the literature. So if you aren't willing to try telehealth, you may be showing your age, just FYI.
Duly noted. It looks like Dr. Burnett has joined us. I'd like to just introduce Dr. Burnett very quickly and then repeat the last question. So Dr. Gregory Burnett is passionate about supporting the military demand signal medic in the field. Military medics face chaotic and stressful situations that require quick action to save lives. And Dr. Burnett's work is bringing portable mobile technology solutions to medics in the field, giving them tools to better treat patients and better navigate overwhelming situations. Greg, thanks for being with us today. So real quickly, I'm just going to repeat our last question. I'd love to have you weigh in. And the question was, what are some of the biggest obstacles in telemedicine today? And are there any commercially available technologies that you think you could adapt and apply to make telemedicine more effective?
Hello, thank you. And I apologize for the technical difficulties joining the meeting. So one of the biggest obstacles is the ability to gather the necessary data on a patient to assess the situation. To make telemedicine more effective, platforms need to support an open system architecture design that will allow them to leverage expansible family of sensors to collect and transmit the patient telemetry data. Being able to support plug and play and new and evolving sensors is key for any adaptive telemedicine capability. So using that kind of principle, that was one of the major design objectives that the government took when developing the Battlefield Assisted Trauma Distributed Observation Kit, or more commonly known as BATDOC. BATDOC supports an open sensor framework, and we encourage industry and academia developing new sensors to apply to receive the freely available sensor plug-in interface source, allowing their sensors to be interoperable with BATDOC and leverage BATDOC distribution, documentation, and decision support. So it's a combination between industry and academia to bring to bear a capability for all service members as well as hospital providers. Over.
Thank you, Greg. So we were talking a little bit more about the impact, or a little bit earlier about the impact of COVID-19 on telemedicine. Actually, in the waiting room before this, we were talking about how it's really brought telemedicine to the forefront in a way it really wasn't before. So in adapting to COVID-19, can you talk about maybe some unconventional partnerships or technologies that you have witnessed making a difference in treating patients, specifically, post-March?
Who do you want to go first, Bridget?
Yeah.
Looks like, Greg, you're ready to go. Well, we want to weigh in on that?
So I'd say, kind of building upon the other topic I had was we're seeing a big influx of wearable sensors making the difference, providing patients in the home situation ability to don and get to its vitals. Ability also to use ambiguous mobile computing devices has definitely been a means to share the perspective and able to gather the remote providers' information needed to provide care.
Greg, can you explain a little bit more? Go ahead. I'm sorry.
No, go ahead. I didn't want to jump in there.
So, Greg, can you talk a little bit more about what that means to get vitals in the home?
So one thing post-COVID is the ability that there's the need to have separation. And so the doctors and providers need to have a more accurate snapshot of the situation at home. And so having wearable sensors to be able to collect the vitals and stream that information to the provider so they can actually use that for their diagnostics and their ability to apply towards any future treatments.
Okay. Darren, you were going to build on that.
Well, what I was going to add in to this topic is that COVID really ignited the federal government's support of telemedicine. So I know we were talking before the call started that the very first time telemedicine was listed in the medical literature was in 1974, right? So 40 plus years that we've had telemedicine in existence. And over the last decade, we've slowly kind of introduced it in dribs and drabs, and it's still not even approved in all states as far as reimbursement goes. And so we go from having this very kind of lukewarm support of it to opening, the floodgates wide open, and it's really changed the adoption and the utilization for it. And I think that's really the biggest, kind of odd partnership, because, an entity like the federal government goes from really being very standoffish about it to pushing it very strongly within just a matter of weeks. And we can see the change in adoption. I mean, literally a year ago at this time, telemedicine for a lot of clinicians was snake oil. And today it's a mainstay of their practice. Without it, they wouldn't even be in business. Their patients wouldn't have the medications they have. And so to me, being in this industry for a decade and a half now, it's just the most profound experience I've ever had in a professional entity. And I've been through, the healthcare reform and through adoption of electronic health records and all these other things, but nothing's changed as rapidly and as profound as this.
I completely agree with this. Go ahead. Sorry.
No, I was just going to say I was absolutely surprised to learn about the date of 1974, and this technology has been around that long. So, Julie, please continue.
I agree. I had no idea, did not know about that article. I think that it's important to realize that, as Darren was outlining, this has been an option for many years, but it sort of became a necessity overnight. And it really opened people's minds to opportunities that have existed for years. I think when we look at communication and in an academic setting, which is where I working with medical students and resident physicians on the military and the civilian side, it's incredibly important to think more broadly about how we supervise learners at all levels. We talk on the phone, we utilize email, we discuss cases. We're not always in the room with the learner, especially when they're upper level. Our third and fourth year residents, I'm not in the office each time those residents are seeing patients. And so we're sharing information and we're staffing cases and we're providing supervision very effectively while we're not in the room with the patient. So if we broaden our minds to this concept, I think it can be really helpful. I think access to care while mitigating risk of fragile patient populations, individuals who have pre-existing conditions, who are immunocompromised, and the patient population with whom I work is clearly in that area, multiple medical and neurologic conditions, and absolutely at risk with regard to the global pandemic. We also have to remember that 50% of our learners are active duty military. We could have no interruption in that educational process. Well, we did pull our medical students from clinical sites initially in March and April and into May. We could not pull our resident physicians. And so we had to ensure that there was no interruption in the educational mission and in the clinical enterprise on both sides. So I think that the graduate medical education programs and training of tomorrow's workforce, which is not an option, they're desperately needed. Training in the virtual world as well as practicing medicine in the virtual world has become a necessity. And
can I build on that, Bridget? Because I think this is something that we really don't talk a lot about as an industry. Interns and residents definitely impacted by COVID and their ability to interact with patients. But even more than that are the medical students. So third and fourth year medical students don't have the ability to quote unquote kind of practice on their own. An intern, somebody after they graduated from medical school, has the ability to practice under the license of another physician. But third and fourth year students are kind of in this limbo. They're not in the curriculum and they're not really able to kind of practice independently. And so they have to work with a mentor. And because of limitations on PPE and try to reduce the risk of exposure and spread of COVID, they've really been put to the sideline. So they don't have access to the same rotation opportunities that you historically do in training. And so one of the things that we're working on is trying to develop a virtual rotation. So I could dial in and I could see a patient in a hospital room and I can have students observing my interaction just like the people participating in this call are observing us having this conversation. And when it comes time to gather the history, they hear how I do it. When it comes time to do the exam, they see and hear everything I do. They hear the heart sounds, they hear the lung sounds, they see, the rash on the skin, they see how the nurse pushes on the belly and the response, and then they can observe the assessment and the plan. So telemedicine is not only opening the doors for treatment in underserved communities, but it's giving us a new opportunity to be able to train and educate students for the future. And so now not only do they understand how to treat pneumonia in a hospital, but they also understand how telemedicine can be used to treat pneumonia in the hospital, which is hugely important.
I completely agree. And I just want to add that I think 2 days into the pandemic, we had medical students. We were one of the only rotations up and running, and we had medical students join us in the virtual room, and we were pulling them into appointments. So they were part of our appointments from the very start, and which is a great benefit to them, but also just the increased the isolation, the loneliness. People with pre-existing psychiatric conditions, those were worsening because of the lack of connectivity and attachment to people, and just being out in the community and circulating, as well as individuals who did not formally struggle with mental health issues. It's become more prevalent. So there's been an increased demand.
Yeah. So given some of the challenges that have been brought to light, what types of cross-field, and what I mean by that is business, aerospace, other engineering fields, et cetera, that type of thing, one of these cross-field partnerships, do you believe would be most beneficial for telemedicine in the future and addressing these concerns? Feel free to jump in.
All right, I'll start on this one. So I think there's definitely a lot of need as it relates to emergency medical services, disaster relief. So much of what happens, let's say during a hurricane or tornado, is infrastructure is destroyed and there's limitations in access to medical services, triage, there's a host of things. And as a country, we really haven't gone full force into the utilization of telemedicine for disaster relief. So I think having a partnership with FEMA, the federal government, being able to staff and stockpile equipment around the country, and then have a cadre of professionals that know and understand how to use the equipment so that in the event that it's needed, they have the ability to set up makeshift clinical workstations in communities and be able to leverage telemedicine for prescribing, for delivering care, and for doing things that we typically try to do with some type of a more physical infrastructure. A lot of care that's needed on a daily basis. Somebody has 10 days of their heart medication left when the tornado hits, and now they have 2 weeks until the local pharmacies set up. Well, how do we get them a refill of the prescription, and how do we manage their care? That stuff can be done locally through telemedicine, and those are the types of things that get lost. So what happens is patients stop taking their medicines, and then 2, 3, 4, 5 weeks later, they're going to the hospital, going to the emergency room because now they're not feeling well and they're having the complications of that. So I really feel like now that we have a greater acceptance of the role and the value of it, we really have to start leveraging it to its full capability.
So I'd like to add on to that. So inherently, as we heard throughout the different panels of the day, it's going to take a multidisciplinary skill sets to really put together a unified package. And so as we start expanding, the infrastructure, whether it be the bandwidth and the communication channel integrity, but just as important to that is the user experience and the platforms that, whether the designs of the UIs or the data capturing mechanisms. And so what we need to do is bring together the specialties and the skill sets as computer scientists working alongside providers, nurses, first responders to really capture the necessary information that needs to be transmitted between those natural disaster relief scenarios. And that really opens up the apertures for future systems to include other leveraging technology such as heads-up displays, audio video processing, wearable biosensors, augmented reality symbologies and overlays, such that we can portray the information in a manner that is not oversaturating the cognitive capabilities of our first responders, but allows for the unified connection between those first responders, boots on the ground, to those doctors at the rear, providing that assistance, so that in a manner that is comprehensible in dynamic situations.
I would just add that at the onset of COVID, one of the things that we ran into was college mental health. And so you have all of these college students at universities who returned home unexpectedly. Many of them were being seen for mental health conditions on the campus, and so immediately lost access to their prescriber. And so one of the things I think we need to look at is eliminating barriers to treatment. And we were talking about coding and billing earlier. That's another issue. We shouldn't have to worry about someone losing their prescriber abruptly and having no options in their own local community. So prescribers were in the position of, do I go ahead and prescribe across state lines? Do I help facilitate this individual find another healthcare professional immediately in their home state? So there were a lot of barriers to treatment, and this is an opportunity for us to look at policy issues and try to rectify some of that. Another way that I see technology being utilized in my patient population is Ohio is a technology first state. And so for individuals with disabilities, this means that there's lots of options available to them. And these have expanded dramatically since March, so that they can live more independently and be autonomous. And so remote monitoring, for example, for someone who needs 24/7 care, do they need a staff in their home, for example, or 2 or 3 staff caregivers in their home? Or can we do remote monitoring where they have access to someone who's on call, and then that there's capability to dispatch someone as needed, but to allow people to increase their independence and make their own decisions and live their own lives more independently. Technology is the way of the future, and will take us there.
Dr. Burnett, I wanted to follow up on your answer. I agree, throughout the day we've heard over and over again the need for this multidisciplinary, user-based collaboration coming together. So how do we do that? I mean, these events like today, where we've got people from all kinds of different fields in the same room having conversations, but how do we continue that momentum? What are your thoughts on how we continue to have those conversations?
I think having these open forums that would bring together the expertise in both the technical side as well as the cognitive side, as well as the practitioner side, and be able to start working through and break down these barriers and these challenges, and then come together as a unified government, academia, healthcare providers to really kind of push together a unified solution that will allow us to provide that capabilities to our individuals who are needing that forward deployed or that telemedicine capabilities.
Okay. I'm going to let the audience know that we are open for questions. So if anybody has questions for our telemedicine panel, please go ahead and submit those while we're waiting to see what questions come in. I'd like to ask each of you to just take a moment and let the audience know how they can connect with you. If they would like to, if they have ideas or they have questions, how they can connect with you personally. And then also, what kind of collisions are you personally looking for? What type of partnerships, what kind of conversations? So if there's people that have ideas and aren't sure whether or not to reach out, that might be a fit. So we'll go ahead and go around the room. Darren, you want to get us started?
Sure. So my email address is a great way to get a hold of me. It's Darren, my first name, DARREN, at innovatorhealth.com, which is our company name, INNOVATOR health.com. And then on there's a ways to connect with us as well. So, feel free. We're looking to change the world, right? We want to be able to preserve access to healthcare in rural communities. So if that's a passion for you and you want to try to figure out how to bring healthcare services to communities that don't have it, whether that's here in the United States or with the military in Afghanistan or Department of State, in another country, we want to be your partner in that. And so, we're always looking. And the other thing too is we wouldn't have gotten here without a lot of great help from a lot of great people. And so if you're in this industry, you're in the space and you have a question, you're like, hey, we're kind of on a different track, but what you're doing is kind of similar to what we're doing. We need, some guidance. Yeah, send me an email, make a phone call and let us know. We're here to help the greater purpose of trying to improve this care. So if there's something we can do to help, let us know.
Yeah, you can reach you can reach me through LinkedIn or possibly connecting the 7-Eleven Human Performance Wing and provide my information. But areas that I'm interested in is artificial intelligence, machine learning, as they are being fed streaming vitals such that our remote medics can actually have that further decision support assistance, as well as any wireless biosensors streaming are of interest to me.
Thank you, Greg.
And my email is a great way to get a hold of me as well. Julie, JULIE .Gentile, GENTILE @Wright, WRIGHT.edu. I'm also available on the Wright State website. That's an easy way to link with me. Our department is really committed to access to service and serving the public sector. We also do some private practice. If you have needs in the mental health area or need linkages, I know it can be difficult to find a clinician, link the right patient with the right clinician. If we can be helpful in that regard, please reach out to me. I'd love to be helpful. We have aerospace psychiatry, we have intellectual disability psychiatry, traumatic brain injury, college mental health, substance use disorder, addictions of all types. And we're interested in linking with in scholarly activity and with researchers, basic science researchers, grant opportunities. Feel free to reach out to us. Another thing that we've done recently, just I guess a silver lining of the pandemic, is that I think that our affiliation with Wright-Patterson Air Force Base puts us on the map in a way that we would never have been able to accomplish. And our military resident physicians, although they are dispersed all over the world after they graduate, this has enabled us to link with them in a unique way to re-engage them as psychotherapy supervisors. And we have a monthly psychotherapy supervisor meeting, and they are meeting with, each one is meeting with a resident 1 hour weekly using this technology. And we just had a meeting the other night. I had 26 of our alumni, military from all over the world on a screen, and we're reconnecting. And it's really because of the pandemic and pulling together.
Thank you. Thank you. So we do have one question from the audience. We've got 5 minutes, so we may not get a chance for all three of you to respond, but I'll shoot the question out there. Feel free to jump in. So the question is from Amy Magnus. She says, colleges are hotspots. There's a lot of speculation why. Can we build awareness of emergent community behaviors to both mitigate or exacerbate the situation? Does anybody have thoughts on an answer to that question?
Yeah, I'll jump in there. Thanks for the question, Amy. So look, I think this is a great use of social media, right? And I think college students are super good with social media, right? So Twitter, Facebook, TikTok, everything. And so I know that Apple, in their most recent update, put out a COVID response update, so that they're tracking COVID in areas. And if the local health department is participating in that, then you'll get updates on your iPhone about COVID outbreaks in your community. So I think between the technology that already exists today and social media, I think there's a great opportunity to build awareness and to let people know how best to stay healthy. And I think that that's the perfect population to really embrace that. Much easier than if you asked, how do we do this for patients in nursing homes? A little more complicated.
Any other thoughts about this question?
I agree that the social media will be that will enable the pyramid effect, and I think some of this was predictable as students congregate on college campuses, and so hopefully these are mostly asymptomatic or mild cases and this potentially will help with herd immunity, hopefully, in the long run.
Dr. Burnett, do you have thoughts?
No, I agree with the other panelists. I mean, the social media is definitely an outreach so we can share information over.
Thank you. Okay, so we have about 2 minutes left. Any closing remarks? Any thoughts you'd like to share with the audience about telemedicine, the future of telemedicine, concerns or excitement? This is your chance to leave us with some final words.
One of the things that I would like to add is that I have patients who have difficulty with social interactions, and in particular, for example, Fragile X syndrome. Individuals with Fragile X syndrome have difficulty with eye contact. It's a social anxiety issue. And one of the things that was really surprising, and it's just anecdotal, but my patients who I'm seeing now via telehealth have better eye contact. They're able to look at me in the eye and have conversations at a level that we could not have facilitated in an office setting. And so I think that as we move forward, and now that telehealth has exploded and it's being well utilized in many arenas, I think we need to start collecting data and look at some of these, some of the opportunities that it affords us. So data collection, studying, research, and I think in general, it's just been an incredibly rewarding experience to me, and it answers some of the supply and demand problems. There aren't enough physicians in these outlying areas. We need to connect people with services.
And I'll just add one real quick thing, Bridget, is if you're in the healthcare industry and you have any inclination to get involved in telemedicine, you should do it. What happens is that when you start doing it when you really need it, you don't have the experience, and those blind spots really become magnified. And so now is the time in a controlled environment where you can make mistakes and you can learn and you can develop. If you don't have a good telemedicine mentor to rely on, that's okay, but just start doing something in the space because you'll learn a lot from the experience. as opposed to either not doing anything at all or trying to do it at the last minute when you really have to try to come up with a solution.
Yeah, I
That
agree.
makes sense.
Telemedicine is here to stay, and we're only going to see in the years to come how these virtual platforms are continuing to advance, and really bringing more connections to the rural areas as well as to providers and patients who are at those separation requiring the need.
All right, that's our time. So basically, what I've learned is telemedicine is here to stay. And if you are looking to change the world, get in contact with one of our panelists, share some ideas, brainstorm. Let's keep the conversation going. A huge thank you to all of you for being here today. Thank you to WBI for making this happen. And let's continue to have these conversations. Thank you, everyone.